Morning, everyone. Welcome to another episode of Surgery Live. Thanks so much for joining us. And thanks to Medtronic for helping sponsor this and making this possible. So with that, I'm going to turn it over to Dr. Asfaw to introduce Dr. Harrington and our trauma topic for today. Thanks so much.
Good morning, everyone. Thank you so much for being here. Today, we'll be talking about damage control laparotomy and management of the open abdomen. Dr. Harrington is a true Cleveland native and grew up about an hour west of Cleveland in Sandusky, Ohio. He went to John Carroll University for his undergraduate studies and then attended the Ohio State University for his medical studies. And after medical school, interestingly, he completed 3 years of an OBGYN residency before making a career change to general surgery. And he subsequently went on to complete a surgical critical care fellowship at the University of Wisconsin in Madison, and then returned home or to near home in Cleveland, Ohio, and took an acute care surgery position at one of our trauma hospitals. In addition to his clinical responsibilities, he enjoys educating residents and participating in simulation and simulation education. And while not at work, he enjoys spending time with his family, and his beautiful newly minted daughter is here on the slides, and woodworking. So with that, we'll turn it over to Dr. Harrington to learn a little more.
So when I was a surgical resident, I thought I knew what sleep deprivation was, but this picture of my 3-month-old, don't let that smile fool you. Having her the last 3 months has really shown me what true fatigue is. As mentioned, we'll be talking about the damage control laparotomy and the open abdomen. My first introduction to the open abdomen was actually as an undergrad. I was reading the book Better, and in it, it's referenced an open abdomen in its use in the military. And at the time, I was non-medical, but interested in surgery. And I was just floored by the option of leaving the abdomen open with some sort of synthetic material. And so that really kind of further piqued my interest in surgery. And I think it's only natural that I ended up in this field. So we'll start off today by talking about a case. This was a 43-year-old female who didn't have any significant past medical or past surgical history. She came in after a 40-mile-per-hour motor vehicle crash. Initially, she was hemodynamically stable, but did have a significant seatbelt sign across her lower abdomen. When she was initially seen by the ER, they did obtain a CAT scan, and when they did that, they saw small bowel pneumatosis and hemoperitoneum. With our involvement, we examined the patient, and at this point, she was actually developing peritonitis, and we decided to take her to the operating room for exploratory laparotomy urgently. So when we got into the OR, the first thing we noticed is as we got through the subcutaneous tissue, she had a significant moral lobule lesion from anterior iliac spine to anterior superior iliac spine. Once we got into the abdomen, though, more concerning was about 500 mLs of blood was discovered in the pelvis. We discovered active hemorrhage from a mesenteric defect along the distal ileum, and this had compromised this portion of small bowel, as well as a devascularized injury to the sigmoid colon from a similar mesenteric defect. At this point, the patient was hypothermic and acidotic with increasing lactate levels. And so we talked to anesthesia, and despite the resuscitative efforts, her numbers were moving in the wrong direction on a follow-up ABG. And so then we kind of took a pause and thought about what to do next from a management standpoint. So after all of the obvious things such as hemorrhage control and control of the dead bowel was taken care of, I just want to see what the audience would do in this situation. And so I'm just going to pose the question, now at this point in the case, knowing what you know, would you move towards a primary anastomosis of the small and large bowel and then and close the patient? Would you move towards a primary anastomosis with proximal diversion? Or C, a small bowel anastomosis with end colostomy? Or D, decide to leave the patient in discontinuity and place a temporary abdominal closure device? And we'll give you a little bit of time here to think through the answers.
So I think the keys here, like Dr. Harrington said, taking into account the big picture and her physiology, do you do something definitive? Do you do something temporary? Do you do something in between?
Okay, well, overwhelmingly of the people who did vote, it was D, which I was happy to see, because if it was some of the other choices, this talk would be very short. So in terms of our operative management, we of course controlled the hemorrhage first, and then we looked at the area of the bowel and we saw clear demarcation. Decided to resect at those portions of the small bowel as well as the sigmoid colon. There were some areas that still appeared viable, but did have some mesenteric injury that we decided to leave. And this in part was knowing we were going to leave the abdomen open. We knew we had the luxury of getting a second look at some interval that we could reassess the bowel. And then we decided to apply a temporary closure device. This was a commercial VAC system. And then we decided to transfer the patient to the ICU for further resuscitation. And so the damage control laparotomy, this is something that was first published in 1983 by Stone, looking at intraoperative hemorrhage in general surgery patients. And this compared traditional techniques with what they called salvage techniques and found a significant survival advantage in the salvage technique, which included packing and termination of the case early within a subsequent operation to actually complete the initial operation. Although this was first published in the 1980s, the idea, though, of abridged surgery and damage control methods was nothing new. It dated back even to World War II. Using salvage techniques at the time, however, was considered to be substandard to traditional methods. There was some thought that if you could not control hemorrhage, or if you decided to abruptly end a case with packing and plan for a second look, it was seen more of a technical deficiency more than a physiologic derangement that the patient was developing that was increasing poor outcomes. And this philosophy really continued into the late 1970s. And it wasn't until then that Lucas and Ledgerwood first pointed out successful use of packing and hemorrhagic shock during abdominal operations. And then finally, we obtained the actual term of a damage control surgery in 1993 when Dr. Rotondo published in the Journal of Trauma, looking at its use in penetrating abdominal trauma. It is important to note, though, although it's grown rapidly over the last 3 decades, it does lack prospective validation. But I think it's obvious to see why we're not going to be able to obtain a study in that format, given the concern for a patient exsanguinating. And so as the damage control laparotomy over the last 3 decades has grown and become more accepted as an approach for certain situations, it has become a little more defined in terms of its approach. And it can really be broken down into 4 phases, 5 if you include the pre-surgical phase, which includes all of the things that we do in traumatic or any sort of hemorrhagic shock, where it's IV access, resuscitation of the patient, early blood products. And then you move into phase 1. And this was kind of where we were in our case, where it was just damage control. It was taking care of the hemorrhage and stopping contamination, and then getting the patient out of the OR and into the ICU into phase 2. And that's where you can continue to resuscitate the patient. The concern here is the classic deadly triad, as we see to the right of the slide: hypothermia, coagulopathy, and acidosis. And those are going to be some of the key things that you're looking for as an operating surgeon when you're trying to implement damage control laparotomy techniques in order to stop the patient's physiologic derangements and be able to get them into a more favorable situation for a second look operation. And then eventually you do need to take the patient back to the OR. And we'll talk a little bit about this in terms of timing and what the importance is of trying to get them back to the OR early, because that's going to go right into our phase 4, is how difficult is it to close this patient, and what are some of the options that we have at our disposal if the patient is difficult to close. And so just to kind of summarize this slide, I think it's really important to just kind of think, especially if you're, a resident kind of early in your training, thinking, what situations would you really want to implement a damage control method? Well, again, it goes back to this triad of hypothermia, coagulopathy, and acidosis. And so a lot of your communication with anesthesia is going to be very important during the case. You're the operating surgeon, but you're also going to be one of the lead person that's going to be responsible for resuscitation. And that communication with anesthesia to see what the gas is the patient on pressors? Where are they in resuscitation? Are they doing one-to-one resuscitation? Are we still behind? And despite those efforts, is the patient still looking like they need to have some sort of a bridged operation to get them to a more favorable physiologic condition? And then it's also important to note there are other reasons to move towards a damage control laparotomy technique. This would be if a patient has a significant ventricular arrhythmia, or if they have a significant heart event intraoperatively, or if you have hemorrhage that's not controlled by traditional techniques, or it's a very complex traumatic injury that cannot be solved in that certain circumstance. And then also large volume resuscitation. And this kind of goes into patients where you might be worried about an abdominal compartment syndrome or one developing. So people who have ruptured AAAs, or even just traumas with massive resuscitation. Even if you can get the abdomen closed and you don't have a particular reason to go back, you might want to consider leaving the abdomen open. Maybe not in a damage control laparotomy technique, but a temporary abdominal closure if you're worried about abdominal compartment pressures postoperatively. And it is also important to note that although, as surgeons, we love to ask residents about the deadly triad and hypothermia, coagulopathy, and acidosis. But it's also important to note in trauma, we also are seeing trauma-induced coagulopathy. And this is an impaired hemostasis that's secondary to increased fibrinolysis. And we see this in trauma patients even independent of hypothermia and hemodilution and acidosis. So even if you're not seeing patients who are hypothermic or acidotic, you still might be seeing patients who are quite coagulopathic because of the natural process of increased fibrinolysis during trauma. And so once the decision is made for a damage control approach, the next phase of care involves the open abdomen. As mentioned above, we also often find the need for temporary abdominal closures in trauma, sepsis, and compartment syndrome. In the United States, trauma is actually the most common, but it's not infrequently that this technique will be used in significant abdominal sepsis cases, or even cases as mentioned above, where we are worried about the abdominal compartment pressures. And so really the big benefits of the temporary abdominal closure is it does decompress the abdomen. So if there's any concern for compartment pressures, that is going to give you a little peace of mind. It is also important to notice, though, that still clinically evaluating the patient is important. Although it's unlikely with some sort of closure device, patients can still have increasing compartment pressures. And so even if they do have an open abdomen, if they start appearing as though they have abdominal compartment syndrome, it is always important to reassess and see if you perhaps need to loosen whatever device you have to close the patient temporarily. And then also it just allows us to have easy access to the intra-abdominal contents for re-exploration. Like all things, though, this is a good tool, but there are negatives to it. And one of the big things that's a challenge for a lot of surgeons who decide to use this approach is loss of domain. And we'll talk about a little bit some of the challenges that we face and some of the ways that we can help to prevent significant loss of domain with patients who have an open abdomen. But also we do have fluid loss, especially in the systems which actually evacuate some of the fluid. And with that fluid comes protein. And there is obvious risk to bowel injury and fistula formation with the use of open abdomen. Next slide, please. All right, so this was another thing, and we'll go ahead and open up another poll question. And I think that this is just a very interesting question because I really have used, one primary method for temporary abdominal closure. And I imagine that there is just some variation in practice based on what's available at individual hospitals and also perhaps some regional variation. But what is your preferred method of temporary abdominal closure? A is going to be kind of a commercial closed suction device. B would be a traditional towel method. C would be a patch such as a PTFE or hook and loop, or D would be skin only closure. Okay, so this isn't all that surprising either, just from my own practice, but it looks like most people are using some sort of commercial closed suction device out there. So in the next slide, you're just going to see a couple of represented pictures of some of the options. So the left side of the screen, this is what most people selected, some sort of commercial vac system that has a peritoneal barrier and does allow for management of fluid. And then the top, kind of going clockwise, is just going to be a temporary skin closure, which can be done just as simply with the use of towel clamps. And then next, you can see kind of a peritoneal barrier, but the next slide actually, or the next picture does show kind of that patch tied into the fascia. And then the last picture on the right does show a commercial product that's actually a dynamic closure system. So as I mentioned a little bit earlier, once you have an open abdomen, then the next thing is when do you get it closed and what's the correct timing for that? And really the key to this is as soon as possible. But before you do that, you have to address whatever process was going on that led you to the open abdomen. So if it's metabolic derangements, if it's coagulopathy, if it's hypothermia, if it's increased abdominal pressures, whatever that parameter was that pushed you to decide for a temporary abdominal closure, you really should intervene, correct it, and then close as soon as possible. Traditionally, we've defined early closure as less than 7 days and late closure is greater than 7 days. And we've seen in many studies that there's actual improved functional outcome in terms of quality of life, return to work, the sooner you get the abdomen closed. And that 7-day mark tends to be a cutoff. There have been studies, though, that show that every hour beyond 24 hours does see a decreased rate in primary fascial closure. And so, you can't speed up a patient's physiology, but it is important to know that once you do have that window, it's good to take them back as soon as possible to try and get primary fascial closure. And so now we're going to talk a little bit about the options for abdominal closure. Our preferred method is always going to be to get the fascia closed. And if you take a patient to the operating room on a second look and you're able to close them, that really is the preferred method. If you're not able to get them closed without significant tension or increase in peak pressures, then that's when you want to start thinking about some adjuncts that you have available. Retention sutures are an option to give additional strength to the closure. You can also use a patch for temporary closure, but things like the hook and loop actually can help facilitate closure by sequentially cinching this down. Now, obviously, with a patch, it is time consuming on initial placement, and you do have to worry about fascial necrosis, but it does have some of the highest primary closure rates in terms of temporary closure devices. And then you can also do other more creative methods such as vessel loops under tension, which can be used in adjunct as well with the VAC system. And then, as I mentioned in the previous slide, there are some commercial products out there that actually have sequential kind of strings that can slowly bring down bring up the tension on the incision and slowly close the wound. If you can't primarily close the fascia, then we need to start thinking about some sort of bridging mesh. And there are different options for bridging mesh, such as biologic mesh and also absorbable meshes. And then there's also options for just skin closure, or after granulation of the wound, you can also look towards split thickness skin grafts. And so I'm going to return to our case and just kind of tell you the outcome, because I'm sure everyone's on the edge of their seat. So our patient was very fortunate in the fact that she had youth on her side. We were able to take her back to the operating room 30 hours after the initial operation. And by this point, her acidosis and hypothermia were corrected. We did thankfully have enough length of the terminal ileum that we were able to do a small bowel anastomosis. And so we did not have to do an ileocectomy. And then we also did a colorectal anastomosis. We opted not to divert her in this situation. There wasn't a lot of contamination, and we were happy with our anastomoses. And then we did move towards primary fascial closure. She had a large abdominal wall mass, but we did figure of 8 interrupted sutures, and that allowed us to kind of bring down the tension uniformly on the incision and get the abdomen closed. We were watching peak pressures during this, and because we were worried about the tension with straining during extubation, we did elect to leave her intubated until the next day. And for the morale lobule lesion, we actually just placed closed suction drains in there, and thankfully those dried up and we were able to remove them prior to her going home. I was really happy to see that she did great postoperatively. She was actually discharged after postoperative day 5, having return to bowel function, and was working with physical therapy and doing well. So I just want to bring up a summary. just really the take-home points is that, damage control methods can be life-saving in trauma, but also in any sort of intra-abdominal case where you have significant hemorrhage or some sort of physiologic derangement that is going to cause the patient to be at higher risk of complications and mortality. Once you've decided to do that, management of the open abdomen is going to be key to return the patient to a normal physiologic state and then get them closed as soon as possible. And then it's also important to know that there are a lot of adjuncts to facilitate closure. And some of these are really good cases to talk to partners who have been doing this a while, because I've really found, just in terms of asking other colleagues that I've worked with throughout my training and also being here, that there are a lot of nuances to it and tricks that people use that might not necessarily be wildly spread in the literature, but are really good tools to help get primary fascial closure.
Thank you, Dr. Harrington, for that wonderful presentation. I want to open it up to the audience to see if anyone has questions. Feel free to raise your hand, chime in, or type a question in the chat box that we'll be monitoring. While we're waiting, I do have a couple questions of my own. Obviously, one of the reasons that we do damage control laparotomy in trauma or other situations are physiologic derangements. And one of the ways that we correct these physiologic derangements is a lot of fluid and a lot of resuscitation. And that can be counterintuitive and counterproductive when it comes to closing an abdomen, because there's a lot of bowel wall edema that happens in that period. And if the early period is defined in less than 7 days closure, I have a concern that it does make it pretty challenging to close an abdomen when you're resuscitating for that long and you have that degree of bowel wall edema. Are there any strategies that maybe you use or that you can suggest in that period between initial resuscitation and closure to really help bolster the success of a first-time closure rate when you go back to the operating room?
I think that's a great question. And I'll say anecdotally, I feel like throughout my training, and it just feels good to see a patient be negative and kind of work towards diuresis. But there's really not been any evidence that diuresing a patient actually reduces bowel wall edema. And it can have some side effects in a patient that, you were actively resuscitating. One thing, though, that has been shown is the use of hypertonic saline. There was a retrospective study coming out of UT Houston about a decade ago that did demonstrate improved closure rates with 3% resuscitation. And there have been other studies that have just shown that the more isotonic resuscitation patients get, that does reduce closure rates. And so that is kind of intuitive as you're using 3% as a means of resuscitation. And then I will say there's also another study that did come out of Vanderbilt in 2007 that showed in trauma patients, starting trickle tube feeds can actually reduce bowel wall edema and improve first-time primary fascial closure rates. But I think this, obviously can only be used selectively. Obviously, if you have someone in discontinuity, that's going to be something that might not make that an option for you.
We have a question from the audience, and it's about the case in particular. Given the patient was stable, why not do laparoscopy instead of laparotomy?
Yeah, I agree that, I think putting in a scope does make a lot of sense. I will say that on the CT scan, she did have a decent amount of hemoperitoneum, and I think that was the biggest concern. Is not knowing where the hemorrhage was coming from, and concern for active extravasation.
And audience, feel free to type in questions in the chat box or unmute yourself and ask. Another question for you, Dr. Harrington. I know 7 days was the window that you gave to go back to the operating room. A lot of these patients are left in discontinuity. Any consideration to that? And can you really go up to 7 days when a patient is in discontinuity and not take them back to the operating room?
I think in those situations, you're likely going to be taking them back for a second look prior to that. It might not be a situation where you're able to put them back into continuity, but I do think a reassessment of the bowel, I would likely do that prior to waiting 7 days without at least doing a vac change and assessing the bowel. Obviously, in these situations, you're going to be having an NG tube with decompression, but obviously, that's going to be a situation where I would likely do some sort of vac change in the interim, even if I didn't think I was going to be able to close. But I will say to that point, every time you take someone to the OR, once you're able to hook them back up, you should always reassess for closure each time.
And speaking of which, taking them back to the OR, say you restore their continuity, but you're not able to close them. Any consideration to extubating these patients, let them walk around the floor of the unit, even with temporary abdominal closure devices on?
So I will say I've actually extubated quite a few patients, and there have been studies to show reduced pneumonia rates when you do that, and it has been shown to be safe. I think this really just needs to be, though, taken at a case-by-case basis. The patients that I think are good candidates are the ones that are intubated on minimal sedation, and you can kind of talk with them and have a conversation and say, we need to be careful. We can put a binder on. But if a patient, is not going to be agreeable to it and can kind of be okay with the mental aspect of having a temporary abdominal closure, I might consider not doing it. And then I also think that you do have to take into consideration the timing for taking them back. If you're going to be taking them back just after the resuscitative phase, in 24 to 30 hours, maybe extubating them just doesn't make practical sense. But I think someone who is going to be there with an open abdomen for an extended period of time, if you can get them extubated, I think the data says that you should try to do it if you feel like the patient will be safe.
Great presentation. I completely agree on extubation when possible, when appropriate with the wound vac. What are your, I think this is, and you highlighted a lot of great points that, damage control laparotomy in the open abdomen has been such a great adjunct to the management of surgical trauma patients. And I think there's been some, as we got going with it, I think the pendulum really swung to everyone was kind of then getting managed with an open abdomen. And you highlighted a lot of the issues of that. People, increased hernia formation, fistula formation, or atmospheric fistula formation. So I think that's the other thing to keep in mind, like you mentioned. Oftentimes it's so difficult to close these patients on the take back because we're flooding them with fluids and blood products and everything, and you get the bowel edema. So I think that's the other thing to kind of for people to keep in mind as you're doing this. If you have a definitive treatment for the traumatic injury and patient is stable, that might not be the patient to do a temporary abdominal closure on. But fantastic presentation. Thanks so much.
You. And I will say that, I do think you were exactly right in terms of the pendulum. We kind of went from it really not being accepted to then becoming perhaps overused in situations. And so I think it is finding that balance where you're using it as a tool for the right patient population.
We'll try and sneak in two more questions. Dr. Rogula, did you have a question?
Yeah, great presentation. Congratulations. This is great management. I have one comment in terms of temporary closure. So I have so experience with using VACs. I remember a couple of cases where those VACs actually created fistulas and perforated bowel. I also tried different kinds of biological temporary meshes. They also tend to irritate intestines quite a lot, especially in bariatric cases. I'm a bariatric surgeon. We had quite difficult fistulas after those. So that's why I voted for temporary skin closure, as this seems to be more natural closure. Of course, it leaves a huge hernia, but my experience so far is the skin is cheap. Second, seems to be a little bit more safe. You have any thoughts, any experience on that?
Yeah, I mean, just kind of from my own experience, I've primarily used VAC systems. I will say, and just some of the things that I kind of do in terms of the VAC is, I always try and make sure that I have, wide peritoneal barrier that I have going all the way down to the gutters. And then just to hopefully reduce the amount of separation of the fascia, I always try to use as small a sponge as possible and really kind of cinch it together manually before putting it, the strips across. I actually personally have not done primary skin closure, but I do think you made a great point that it is very cost effective. It's fast. I'll say there was one study that I did come across just with the towel method, which obviously is different than the skin closure, that did see slightly higher mortality rates compared to a VAC system. And the authors actually postulated that they thought it might be from cytokines being removed in peritoneal fluids during kind of abdominal sepsis that was obtained with the VAC system versus the towel method. But obviously with the towel method versus a skin closure, you are going to have some passage of fluid with a towel closure. And like I said, that thought of reduced mortality was just a postulation and not proved.
I know we're over time. There was a question from the chat box though. Thoughts on using PD solution for DPR for the open abdomen?
Is that thinking of like intraperitoneal resuscitation? Was that the question?
I believe that's what the question.
So I actually, when I was in fellowship, we did have a patient because one of my attendings at the time had actually used intraperitoneal resuscitation and in fellowship, and we didn't want to use it on a patient, but we really found that there really aren't a lot of great protocols for it, and it was very difficult to implement. But there have been some centers that have had success with closure with either 3% or other solutions where you actually give intraperitoneal resuscitation. So I think that's something that if you're at a center that has a protocol for it, implementing it could be feasible, but it might be a little challenging if it's not already established at your facility.
Okay, thank you so much, everyone. Thank you for the great questions, Dr. Harrington, for a very insightful presentation as well.
Thank you for everybody's attendance.
Phenomenal. Thanks so much, guys. As a reminder, we'll be right back here next week for Surgery Live with a bariatric surgery topic of one anastomosis gastric bypass, not a mini procedure, with Dr. Aminian moderating. And as a monthly reminder, we meet every Friday with the exception of the first Friday of the month, rotating through all the general surgery subspecialties. And thanks again to Medtronic for sponsoring and making this possible. Thanks for tuning in. We'll see you next week on Surgery Live.